Good evening. This is Dr. John Bennett broadcasting for Neurosurgical TV in home of Nepal Medical Center and Ip Cherian, noted neurosurgeon, neurosurgical wing. Ip is also president of the ACNS, which this lecture is part of the ACNS Neurosurgical Students Society. And we have the pleasure tonight of having, they call him the Croatian Wonderkin. He's a neurosurgical aficionado from Croatia. He's going to give a lecture on one of Albert Rhoton's series. And we're also joined by a medical student from Romania, Elena. We're going to introduce her first. Hello, Elena.
Hello, Dr. Bennett. Thank you for the introduction. My name is Elena Neftian. I'm a fourth-year medical student. I'm very passionate about neurosurgery, and this year I am the vice president of the Walteri Dendi Neurosurgical Club, which is a chapter of the Walteri Dendi Society here in Romania.
You're welcome, Elena. Hope you become part of the group. And our special guest from Mexico City, driving, Victor Hugo. How are you doing, Victor?
I'm going to hear the interesting talk for Slaven, but I'm only here because I am I am driving.
Well, that's.
But I'm okay. I can hear.
Okay, good. Well, welcome, Victor. This is what do you think of that, Slaven? This is 21st century technology. One of the world's foremost neuroanatomists coming to see you give a presentation. And welcome, Slaven. It's all yours.
Thank you very much, Dr. Bennett, and appreciate it. It's so beautiful to see Dr. Perez in action. As there was one point when I made a little poster for neurosurgical TV with Dr. Perez driving and listening to lectures. I mean, it's like the thing that we want to do here, I think. So I'm really, he always brightens up everything, and I'm really happy to have such esteemed colleagues on the panel. As you know, I'm a long-year bloke who is studying Rhoton and trying to indulge into his neuroanatomy, which is mostly intracranial anatomy. But what Dr. Perez is doing is also captivating me because, as you probably know, he is trying to develop a book on spinal anatomy, and I really hope that this will be a nice addition, and one day I will talk about Perez's anatomy. So today it's nice that we will continue with this Rhoton course. My lecture of today is going to be a continuation of the lecture I tried to give on Tuesday. We had some technical issues, but hopefully today I will finish it, and it's not going to be long. It's going to be very consistent. So I'm going to try to share. Again, I hope you can see this screen here.
Yeah. Yes. Looks good.
Okay. Great.
Great.
Wonderful. Wonderful. Okay, so basically the title of today's talk that I will give is telovelar approach to the fourth ventricle, and it's intended to be kind of an overview of the posterior fossa anatomy, intermingled with some neurosurgery, and I really hope that one of the most important studying goals I have for tonight or today is to for us to appreciate the cerebrovascular complexes that Professor, I think, very nicely described this in this posterior fossa. It's going to help you really to gain some better understanding of all the structures of anatomy which are present in the posterior fossa, making it the most complex of the. So I'm going to start now. As you see here, this is just a skull-based clock, as I like to call it, which shows you various approaches to the skull base. And now, as we go from forward to the backside, we can appreciate some approaches which are, first of all, midline, I don't know if you can see my cursor, but I'm showing here the midline of the skull base. And these approaches can be anterior midline or posterior midline. Again, these approaches can be more or less upwards or lower, meaning that you can do, for example, this transclavial approach, you can do it transorally and endonasally, which is the usual way some regions are approached today. For example, pituitary region tumors. And also in the back, as I will show a minute later, you can do them in the top of the occipital bone, in the middle, or suboccipitally, which is kind of a point that we will do today. Then we have the lateral approaches. First of all, anterior petrosal and middle fossa, which are approaches which bring petrosal, transtemporal, and retrosigmoid. These are approaches we will discuss later on in the course. And
Excuse
finally,
me, Slaven?
yes?
Yeah, could you get
Yes,
rid of
please.
that banner at the bottom? It says Google Hangouts is screen sharing.
Oh, I
Just click
see.
on
Hide.
hide.
Yeah,
There you
okay.
go. Perfect.
Okay, thank you. I didn't know it shows. Okay. Okay, so and finally we have the far lateral transcondylar, very interesting approach, which we will do after we discuss the retrosigmoid approach, outlined here. And then finally, for today, we have the middle approaches. Again, we will concentrate today on the specific approaches going through the suboccipital region of the occipital bone. So this is the occipital bone, and this is the suboccipital region, which we will try to discuss today. Note, please, that here you have this groove, which is basically that the attachment of dura in the posterior fossa, which is also the seat of the inferior sagittal sinus. And please keep information in your mind as we go further. I will tell you later on that it's very important in these approaches to not to ligate cut the inferior sagittal sinus before proceeding suboccipital approaches. Okay, so here are some videos, but I will try to pass them because I want to concentrate really on the anatomy first. As you know, there are various ways in which you can position your patient. For example, in pediatric neurosurgery, usually the position face down is done with the head of the baby towards the surgeon, and also slightly tilted downwards. So in this way, the surgeon can best have the best overview of the occipital bone and these parts of the skull which are important for this region. And in adults, you can do it basically, or as I talked about on Tuesday, through the sitting position, which is controversial today, or you can place the position in the patient in the lateral positions, even supine. I mean, with face down. So there are many ways you can position the patient according to the practice in that in the hospital. So now we are going to discuss what do you see of anatomy when you finally open the dura and enter the intracranial space. This is the most complex part. So we will start discussing it first. What you see here is a beautiful Rhoton image showing the anatomy of the fourth ventricle after the cerebellum has been removed. The only parts of the cerebellum that remain here are the pedunculi of the cerebellum and flocculus, which is here. Flocculus is one of the first parts of the cerebellum to develop in human embryonal development. We will discuss this a bit more later on. Finally, you can also appreciate that there is C1 or atlas here, which has been the posterior arch of atlas has been completely ectomized here, and it's removed. Sometimes in these approaches, it is important to be able to approach the upper part of the medulla. And for really shows the place where this junction of the medulla and spinal cord is positioned. Finally, one very important structure here is the vertebral artery, which you can appreciate here. It's basically curls up and inside to the posterior fossa in front of the brainstem here, and creates a basilar artery, which we will see when this part of tissue, the medulla, is removed. Also, the posterior, the floor of the fourth ventricle, the rhomboid fossa, is present here. Okay, so now as we remove this medulla, we see how these vertebral arteries connect with each other and form a midline structure called the basilar artery. As I said, and this will be shown better in the future presentations, this region is quite, sometimes it's very complicated to be approached by neurosurgeons. And usually the aneurysms in this part of the artery, so the basilar artery, can be fatal, and they are very, very important tissue anatomically speaking in neurosurgery. I hope that Dr. Perez or some of the panelists can give further information about this, but as far as I have the information, this is a very inaccessible region. This stem of the basilar artery. These are the main arteries we will discuss tonight, okay? And they are very, very important landmarks for our anatomy tonight, and to, in a way, understand the complete anatomy of the posterior fossa. So these are the pica, ica, and SCA, okay? So basically, some people call this SICA, to be like pica, ica, and SICA, or SCA. This is the posterior inferior cerebellar artery, anterior inferior cerebellar artery, and superior cerebellar artery. These are the arteries which irrigate most of the structures in the posterior fossa, and mainly cerebellum and parts of the medulla oblongata. One of the reasons why medulla is such a dangerous surgical area is basically because there are many perforators, many perforating branches with these arteries give. You can see some of them here. And basically they infiltrate the brainstem and give the irrigation to the inner structures in this way. Also, as I always show, some of the large points in Rhoton anatomy is to have this kind of see-through X-ray vision, as Professor Rhoton always stated. So his intent is to give you an approximation. Rhoton anatomy is to have this kind of see-through X-ray vision. Sorry, I can hear my voice in the I will ask kindly all panelists to mute because it's complicating my. Okay, thank you very much. Okay, because I heard an outburst of my voice, so I really didn't hear myself. Okay, thank you very much. So this is basically the asterion, which you can see here. It's basically the part where three sutures combine. This is the lambdoid suture. And basically it shows you where the junction of the transverse sinus and the sigmoid sinus lies here. So it is a very important landmark when you plan the approaches to the posterior part of the posterior fossa. That means to the through the occipital bone, because this is the margin of the occipital bone here. And basically it's very important to know where are some vitally important structures which you need to avoid during surgery and be aware of. We will see this in much detail when we will discuss the retrosigmoid approach, which basically the burr hole is placed, or craniotomy, around here. So very close to the transverse sinus. And sometimes it needs to be, how can I say, you can see the transverse sinus and sigmoid sinus even sometimes, and just to have them in your perception while approaching dura and other structures, because the rupture of the sinus can be a very, very important and big complication during surgery. Also, it shows you nicely how this region is close to some very important other anatomical things else. and this is the outer acoustic meatus. So basically, much important ENT and neurosurgical structures are located here. Also, we can see here somehow the, let's say, the demarcation point between ENT surgery and neurosurgery. They usually say it's the arch of the zygoma, but I would say that basically this is more of an ENT area and more of a neurosurgical area. These, of course, there are combined approaches which do both neurosurgeons and ENT physicians here, surgeons. So finally, we will start discussing the cerebellar surfaces. Basically, you have here the superior surface of the cerebellum, which is, as is probably logical, irrigated by the uppermost cerebellar artery, and this is the SCA, or SICA as they call it. And basically, you can see the branches of the SCA branching on the upper surface. This is also called the tentorial surface because the tentorium cerebelli lies just here. And as you can see, there are many sinusoid structures surrounding the cerebellum around. This is basically the start of the superior sagittal sinus as well, here where the tentorium lies. I would say that this image is very important because it shows you also the surface that is retracted down when you are doing the supracerebellar infratentorial approach. This is one of the more upper approaches. I would say the uppermost approach in this infratentorial region, where you can operate on some structures in this anatomical region. Basically, there are some tumors which are operated, and many interesting cases have been reported where this area really enables surgeons to combine the infratentorial and supratentorial surgery. And that's a point that I wanted to mention. Also, some cranial nerves are located here, as you can see, the fifth nerve, and also others, sixth nerve, and the mesencephalon, which is here. Now we will approach this superior cerebellar fissure here and see further how this SCA branches inside of it. So there are many branches of the SCA which really dip into this fissure, and they are very important here. Probably have understood by now, since the basilar artery from which the SCA originates is located in front of the brainstem, we can see here that it needs to curve around the brainstem to the posterior surface and irrigate the superior surface of the cerebellum, which is located here. So basically it curves all the way from here to the backside. And on its way, which is very interesting because of one of the diseases which are, how can I say, one of the very presented diseases. This is basically a loop that goes down and lowers itself during, as not all loop exists, and age basically it's in some people it reaches the trigeminal nerve, which is here. As you know, the trigeminal nerve is the main sensory nerve of all the face. And basically, sometimes when it reaches the trigeminal nerve, its pulsations can cause one of the worst pains ever to be experienced by a human being. It's 10 out of 10 on the scale of pain, and it's the trigeminal neuralgia. So this is basically the way that atomically trigeminal neuralgia develops. The operation for this was invented by one of the pioneers of microsurgery, and that's Peter Janetta. He was an American neurosurgeon who was, he looked kind of like a James Bond, I would say. He was really like, how can I say, a very interesting figure, and he basically invented a surgical approach through the backside, doing the retrosigmoid craniotomy, through which he put a piece of Teflon right here between the loop of the artery and the trigeminal nerve. And this was enough to cushion the pulsations of the artery, and in this way to stop patients from feeling such excruciating pain. Of course, surgery is always regarded as the last resort option for patients, but in this case it can really be helpful, and I really saw some. It's a remarkable recovery that a patient can do from being almost disabled by this pain, excruciating pain that really caused him to fear every step, and patients really develop psychological anxieties which are very bad because of this. And this surgery has many therapeutic options. I wouldn't say that it's a simple operation, but basically the concept behind it is very simple. Put the cushion between the artery and the nerve, and you will stop it from being excited. And that's very interesting. Also, you can see something of the Rhoton's ingenuity in this picture, because he put here the picture which is an anomaly. You can see here the two loops of SCA. Usually there is one loop. But in Rhoton's neuroanatomy textbook, one of the most appreciated things I would say is that he gave the real values of segments of arteries, variations, and it's really an encyclopedia of anatomy in its way. It's in a limited number of cadavers, but there are it's usually enough significant number to see these things in practice. And finally, as we go on, we see here that this surface, as we go further down, or caudally from this region, we see the anterior surface of the cerebellum, and this surface is called the petrosal surface. Why? Because it's really looking at the petrous part of the temporal bone. So this is the petrous part of the temporal bone, and somehow the surfaces of the cerebellum tend to be called by the anatomical structures they lie adjacent to. So basically, since this part of the cerebellum lies adjacent to the temporal bone, this is the petrosal surface of the cerebellum. And again, if we show this on another image, it shows the anterior aspect of all of the cerebellum. The cerebellum basically is a structure that is completely continuous here, although it seems interrupted by the brainstem. What is between the brainstem and the cerebellum is actually the posterior, the fourth ventricle. Okay, so cerebellum is forming the top of the fourth ventricle, while medulla is forming the anterior portion of the fourth ventricle. Laterally, we see the flocculus and foramina of Luschka. So very interesting. Foramina of Luschka are, I cannot really express my fascination with these foramina, because when I listened to neuroanatomy at the medical school, I really didn't have at all the sense that foramina of Luschka are basically the communication between the posterior part and the anterior part. So as you can see in this image, when we zoom this a bit, the foramina of Luschka are here, and they are basically located in the front and lead to the central part of the fourth ventricle. Now this is really amazing, because it allows to think about surgeries which can be done from the posterior part up to the anterior. Although it's very important, I mean, because it's very complicated because of the very narrow corridors that lie here. But I just wanted you to remember kind of that Luschka is amazing because it connects the anterior part, or the petrous surface of the cerebellum, and the inner part of the fourth ventricle. And also, I mean, this is described really in detail in Rhoton's textbook, but since you can find those information there, I will not really really strangle you with all the details now. Also here, below the pons, you can see the sixth nerve, or abducens. You can see the seventh and eighth nerve, and how they cross basically here. You can see the trigeminal nerve, or the fifth nerve, and you can see the lower cranial nerves. This is the hypoglossal nerve. This is the 11th nerve, 10th, 9th, which all go to the jugular fossa, which we will see a bit later. And finally, when we include all the arteries and everything, it gives such a sense of complexity of this area that you really can say that this is the most complicated part of the intracranial space. And that's why in my Rhoton course, we start off with discussing this area, because anatomically it gives, I think, the multitude of information. And if you tackle first the hardest part, then you really have a window when you go further. So basically, that's why we start with this. And finally, branches are very interesting because these are all the perforators. And as you can see, almost every artery here, and that's true, gives the perforators which enter all of these cerebrovascular structures. If we zoom out, we can see all the complexity of this area. And this picture is very important for us now, because I would like to take a minute now to concentrate on one of the major points I want to make today. It's the point about cerebrovascular complexes. This is usually too complex for medical students when I discuss this in my usual Rhoton talks in Zagreb University. But I really think that we can go through this. If you look at all this complexity, it really gives you a sense of nausea. I mean, you cannot really grasp all of this, but there is really a very convenient and easy way in which you can really get the knowledge of this and never mistake which part goes where and stuff. And it really is only organization of all these structures. So if I tell you that this is the SCA, from bilaterally, and that it curves, as you can see here, around specific structures of the brainstem or medulla oblongata and of the cerebellum, and also around the specific cranial nerves. And basically put in a table all these structures that SCA comes in contact with, and call all of this the upper cerebrovascular complex. As we go on, if you see that this is the ICA here, and if you see that ICA does the same thing, it reaches the of the cerebellum, it reaches some of the nerves, for example, 7th and 8th nerve. 5th nerve is part of the SCA complex, but it seems adjacent to here, and specific parts like the lower pons of the medulla oblongata. And finally, if you see pica here, which curves to the suboccipital hand, and then you can just name it the upper cerebrovascular complex, the middle, and the inferior cerebrovascular complex. Very important here, very important, is that you don't forget the SCA, the ICA, and PICA, because these complexes are defined by the contacts, anatomical relationships of the SCA, ICA, and PICA. So basically, you just need to know that SCA curves and irrigates the superior surface or the tentorial surface of the cerebellum. ICA curves in front, just like, and it irrigates the petrosal surface of the cerebellum bilaterally. And finally, pica, which is the most variable artery of the three, it irrigates the suboccipital surface of the cerebellum. So this is very, very important, and it can be to locate yourself. So then when you have the pathology in the posterior fossa, you can only say, and it will be enough for a neurosurgeon to understand, or a neurologist, whether it's located in the upper cerebrovascular complex, middle, or inferior. And boom, that's it. It's basically very simple if you look at this like this. Basically, of all this anatomy, you just need to be aware of basilar artery, SCA, ICA, and PICA, and you can grasp all of this knowing three names: superior cerebrovascular complex, middle, and inferior. I hope this makes sense. I can really go back and discuss this again if it's still unclear. And finally, here, what I wanted to make is this thing here is very important because it's, as I said, the pica is the most variable of the three arteries. And what it shows here is that pica can sometimes loop outward from the foramen magnum. Sometimes in surgery, this can be confused. This can be confused for something else, for some irrelevant branch of the artery, and it can be sacrificed. And if this is sacrificed, you will cause infarction to the wide part of the medulla oblongata and the brainstem, which can be lethal. If not always, I mean, almost always this should be lethal. So basically, it's very important to know that pica is the most variable of the three. We are already approaching kind of the ending part of this session for today, so no worries. I won't drag on too long. And we will just discuss some significant parts of neurosurgical approaches. So basically now, as I discussed, that most of these approaches are going from the back side to the front. Here you see a portion which can be seen in the retrosigmoid approach, the best. If you make, I'm sorry again, can you please mute, because it's I hear some loud noises which are okay. So basic, thank you very much. It's hard for me to how can I say, to hear myself when it's loud. And now basically, if you retract the cerebellum, we will discuss this in some of the further hangouts, but today just appreciate that if you retract the cerebellum from the posterior side, you can see the cranial nerves. And this is very important because it allows you to kind of very, very conveniently approach these regions. Of course, this craniotomy goes through the lateral part of the occipital bone, lateral upper part, adjacent to the transverse and sigmoid sinus. And then when you open the dura and retract the cerebellum, you see these structures. And now we can identify these structures as the 7th and 8th nerve. Of the internal acoustic meatus, and then the internal acoustic meatus to reach their curve, and finally this fundus of the meatus. This fundus of the meatus is transversed by Bill's bar. Bill was the ENT physician who was famous for his eponym of the Bill's bar, which can be better seen here. And this is basically a structure that divides the upper portion of this fundus and inferior. I really like to show this picture, although I know it can be sometimes frustrating because of all the anatomy. I like to show it because Rhoton really managed to do dissections so precise that you can see these structures. I mean, it's really, everything is here. As a student, I mean, when I was learning anatomy in med school, I really always tried to imagine these structures, and I never could put them in the 3D perspective as nicely as they are shown here. So because of this, I just wanted to mention all the structures. And finally, you have the superior vestibular area, inferior vestibular area, the facial area, and finally the cochlear area. This is the, this is the fundus, as we see. So this is the superior vestibular, inferior vestibular, the facial area, and finally the cochlear area. And what's more interesting here is that you also have, it's very logical if you look at it. I mean, if you see that there are 3 vestibular semicircular canals, okay, which give us the sense of balance. Then you know that there must be 3 nerves which really innervate these structures. And if you see, there is superior, inferior, and lateral semicircular canal. And with this, you see that the superior vestibular nerve innervates the superior canal, the nerve innervates the inferior canal, and singular nerve, which is here, or this is the branch of the vestibulocochlear nerve. It innervates the lateral canal. It's really, really easy to grasp. And also you have here, you should, it's not really visible so good, but there is this tractus spiralis foraminosus, which is spiral shaped, and it really gives all the little branches which approach the cochlea and innervate the acoustic organ. So it's very interesting how these structures are organized according to knowledge. I'll go back a bit and show just this structure. Sometimes ICA can also be variable, and it's important to know that ICA can loop inside of this meatus and also cause some of the neurosurgical problems. For example, one of them is hemifacial spasm, which occurs because of this. As you can see, the ICA loop here presses on the facial nerve and causes the hemifacial spasm, which can also be tackled surgically with putting some Teflon patches inside, or manipulating the loop of ICA in order to lower this pressure. And finally, one remarkable structure here is the nervus intermedius. I always ask people who are listening to this, what is this structure here? And really, it's hard for people to say that it's the nervus intermedius, because I never imagined it like this. But nervus intermedius looks like a set of nerve fibers between the facial and vestibulocochlear nerve, and it can sometimes consist of as many as 16 separate fibers. So it really gives some complexity here, the ICA and the nervus intermedius. And if we watch what is adjacent to the petrosal surface, we see this enormous anatomical diversity here. So if you would completely be able to see the posterior part of the petrous bone, the porus acousticus internus, here the jugular foramen with separation, and with the 9th, 10th, and 11th nerve, jugular bulb, and the endolymphatic sac, which is located here with the endolymphatic duct. This part of the bone has been drilled out, and it shows the origins of the semicircular canals as well. So really a vast anatomical diversity in this area, and this is the trigeminal nerve. And as we go further, basically, one more thing to appreciate is the proximity of the carotid artery to this. All of this is located, and this really, I think that it's really right to say that temporal bone is the most complex. I think the most complex anatomical area of the human body. Okay, and finally, coming to the telovelar approach. So up to this point, we discussed how the cerebellum is irrigated, number one, how to find your way in all the anatomical diversity of the posterior fossa regarding the cerebrovascular complexes. Okay, this is number two. And now we will appreciate the telovelar approach. So as now we recognize all of these structures, we will try to apply our knowledge and to very briefly, in a few minutes, discuss this approach. So in cerebellum, the situation is very much similar. What you see when you do a suboccipital craniotomy, to be more precise. So when you cut through the lower part of the occipital bone, after opening the dura, and ligating, of course, the inferior sagittal sinus, which is located here in the dura. So let's say you ligate it proximally distally, and you finally open the dura, attached it with retraction sutures to the parts of the surgical field, and now you approached the cerebellum. The situation here is very similar to when you open the mouth and say ah, because you can see the uvula and you can see the two cerebellar tonsils on the sides. And basically in the cerebellum is the same. You have the uvula in the midline and you have two tonsils on the sides. These are very important landmarks for our telovelar approach. And now if you retract one of the tonsils, as shown here, so this is the
preparation for this, and now you retract it. You see this paper thin membranes separating the tonsil and the uvula, and if you open them, finally get the approach to the fourth ventricle. Now this is a bit skewed. I will show you better this in this more diverse picture. So basically this is the vermis again, uvula, the lowermost part of the vermis, tonsils, the suboccipital cerebellar surface. So you did a suboccipital craniotomy. You ligated the sinus, which originates here. Okay. You open the dura, and now you retracted the tonsils, cut through this medullary inferior and through the tila choroidea. These are the paper thin membranes. And finally, you approach the fourth ventricle. And as you can see, it really gives a good exposure to the fourth ventricle. And if you do this bilaterally, you really see that it's really helpful. Now, why has this approach been developed in the first place? In 80s and 90s, these most of the tumors of the posterior fossa of the fourth ventricle, or which really spreaded to the fourth ventricle, were operated through a very, I would say, barbaric approach. I mean, which was not really, it was not minimally invasive in any case, and it was kind of, you know, it's a very historical thing, because neurosurgery is considered by some people very, how can I say, crude regarding to the organ on which it operates. So basically, in the past, surgeons would go through the vermis. They would split the vermis, and then they would gain an unlimited exposure of the fourth ventricle. But after the patient was recovering from the surgery, and when he woke up, in some number of patients, there was this transient cerebellar mutism that appeared, and basically patients couldn't speak for as much as 4 weeks after the surgery. After that, they regained their speech. And if I mention that in the beginning of the 20th century, we have articles from prominent figures in neurosurgery, such as Victor Horsley, who was really the first neurosurgeon, as they say, and one of the fathers of neurosurgery. He mentioned that, as I cite or paraphrase, that large amounts of cerebellar tissue can be dissected and removed without any noticeable neurological deficit. As if you do not touch the deep cerebellar nuclei. So basically, this is really interesting. And then we came to 21st century and today, where you try to find for everything a minimally invasive approach. And if you look, it's very simple. You just go through these anatomical membranes, which are not really neural tissue in a way. You gain a very good exposure. So now the approaches to this region, as far as I am informed, are done through the vermis only when the pathology is in the vermis. As Professor Rhoton himself stated, he said that the only time he goes through the vermis is when the tumor is in the vermis. And now let's just finish this up with few slides about when to use. So you want to use this approach to enter the fourth ventricle for biopsy or to remove the pathology, the tumors of the rhomboid fossa, or you can even approach the sylvian duct for surgeries on non-communicating hydrocephalus when this is indicated. This approach is contraindicated in cases of spinal instability, which can be in very young infants, which really didn't develop the CC junction, craniocervical junction stability yet. And finally, when you have cases of diffuse pathology of the fourth ventricle, then you do not then you can really be more radical in dissection of the structures. And now some cases, and it gives you two alternatives in which you can approach these things. For example, this is a case where you have an obstruction. This is the non-communicating, and this caused hydrocephalus to appear. This young child. And basically, you have two approaches. You can go either intrahemispherically, and go through the third ventricle to this region, or you can go suboccipitally and approach it through the stylovelar approach. And this is interesting, I mean, to discuss which approach would you choose. I don't know if you are in for discussion, but I just want, maybe it's better if I just go through these examples and then we discuss later. An interesting case. This is actually, as I found, a meningioma, and it arises from the occipital part of the cerebrum here. So very interesting case. And finally, this, and I always ask people who are listening to this, would you go through the telovelar approach in this case, or would you go through the vermis? And the answer, of course, is through the vermis, because the pathology is in the vermis. And that sums up kind of what some of the points that I want to make. Finally, a brief discussion of the tumors of the posterior fossa. They are more common in children and adults. As you can see, almost 70% of brain tumors can arise in children in this region. In adults, it's only 15 to 20%. Most common are metastases in both groups. Cerebellar astrocytoma is most common in children, and medulloblastoma is the most common malignant tumor in these children. This is really a case of medulloblastoma with calcifications and really located inside of the vermis. Finally, ependymomas, choroid plexus, papillomas, dermoid tumors, hemangioblastomas, so some developmental tumors. And we found the vast majority of tumor pathology in this area, and that's why, because tumors are resectable structures, they require resections. It's very important to know detailed this anatomy. And this really, look, for today, the next time we will discuss the far lateral approach. But before that, we will really again go through some of these slides and discuss in more detail the retrosigmoid approach. So I thank you very much. Exhausting.
Okay,
I'll
very
go
good.
off the.
Now you can see why they call him the wonderkind students in Croatia. Let me just comment before we turn it over to discussion that, you know, I'm not a neurosurgeon, but being around neurosurgeons for a while, of knowing neuroanatomy, and it's not just something that's studied during the medical school or residency of neuroanatomy. And with that, I'd like to say welcome to Samer. Hello, Samer. Do you have any comment? You want to introduce yourself first and give some comments to the wonderkind of neurosurgical students?
Hi, everybody. Hi, John. Hi, Slaven. Hi, Yusuf. And hi, Ilana. I don't know if the voice is clear.
It is very
Yeah, we
clear.
can hear you.
Okay.
Yes, thank you.
So, just perfect presentation, Slaven, as expected. I like it. And
Thank you so much.
I want just to comment a little bit. Maybe the previous time it was offline, not live, so I want to record this. Especially for medical student and even for any neurosurgeon, resident neurosurgeon, neuroanatomy is a continuous studying. Really, I was following your pictures. It's very important even for me as a new neurosurgeon. So first of all, I should tell that what we said before about the Rhoton collection, maybe what's the difference in Rhoton and other neuroanatomy around the world is the clarity of picture, the different views, and we say that he usually use 100 cadaver. So whenever he found any abnormality, it will be as percent. Maybe in 5 cadaver there is double artery, so it's a 5%. It's easier to appreciate, and how we can study it. I think all of us will see these questions that can anybody summarize Rhoton That's the most important. If you study Rhoton, so you know you will spend a lot of times maybe in 1 or 2 paper. Can anybody summarize Rhoton? I can give an idea about it that actually it's not beneficial. If I want to summarize Rhoton, maybe for the first time I read it, it will be different. For the second time, it will be different. I need something different, you know, from Rhoton. Maybe for the first time, you need only the parts of the arteries. You need to know M1, M2, M3, M4 without the perforating, because each one has maybe 10 perforating and each perforating has blood supply. With the second time, you need another some type of summarization. That's the difference. That's the point that to be mentioned, you know. And maybe at a later stage, when I am now studying Rhoton again, maybe this is the 6th or 7th time, I'm like studying about what are the obstacles for the surgical approach, what I should not meet, what I should avoid during this approach, and what are the landmark, what I should depend on. And as a landmark, you know, something with you, which is the landmark, I need it, and something against you, which are the obstacle. What should I expect? And mainly the obstacle is a combination of good anatomy and good radiology pre-op. So each patient has a different anatomy or variation. That's the main point I want to say. And the other point is that I don't know if I have a time like 2 minutes or 3 minutes, John, Slaven, if you allow me, I can I slide share something?
Yes, of course. I would just like to mention that I need to.
What is it?
I need
Since
to.
you're going to talk about his lecture.
I need to put a charger on my laptop, so I will, because my battery is running low. But you are really free to share, because it's really golden, I think, what you are giving us. Summer.
Just want to complete the topic that you start, and I want you there.
In addition to this, yes,
So
for me, it's really great to have an opinion from someone who is so ahead. With his, you know, it's really helping me to get the perspective on this. So thank you very much.
Okay. And
please go ahead.
You will be back?
Yes, I will. I will just
We'll wrap up the show, Samer.
No.
You want to make a presentation? No, Slaven, we're going to wrap up the show. And then
No.
if you want to give a presentation on your idea, that'd be fine.
I just need to connect. I just need to take the cable and connect it. It will take me like 2 minutes.
I will complete it now. It's just like a little continuation of the Slaven lecture. Yes.
Maybe a minute. Yes.
Yes.
If you have some comments, and then I will go back. I just need to take the cable from the other room. Thank you.
Okay. And John, I can share it now. The slides.
Yeah, go ahead.
Okay. Because I need it on the same. Maybe. Sorry. Is it okay now?
Yes.
Okay. So hopefully this is a recorded video, so I don't need to repeat. This will be available later for those who want to repeat it. So this is the point that Slaven mentioned previously about there is 3 areas in the posterior fossa, all related to simple artery like the supracerebellar artery, and IK, which is the anterior inferior, and PIK, which is the posterior inferior cerebellar artery. So these are another presentation, and each one has a special relation like cranial nerve and also the sister. So these are the 3 arteries, 3 cranial nerve, and especially each one has a different approach. That's why I put this slide, that this is another meaning of what Slaven said, that it's not only anatomy, it will make an implication on the approach that we will use. Another point is that these are all shown, all approaches to the posterior fossa, and maybe after studying what Slaven said today, I can ask somebody what you expect if you use this approach. If you use this approach, I want you to put it in mind that when you are studying, you are a surgeon, and you will be a surgeon maybe, and you are a surgeon maybe according, and you must think of it like this. If I use this, what I will find in my way, what's the obstacle and what's the landmark. So it's very variable. Another point is just when I want to decide how to approach to the posterior fossa, I just want to add 2 points very interesting. It's according to the picture. If there is a lesion, sometimes nobody maybe need this sagittal section. When we either want to go above the cerebellum, we call it supracerebellar approach, like the lesion Slaven just shows in the MRIs, and sometimes there is the lesion down, so need the infracerebellar approach, and the infracerebellar approach either through the cerebellum, which is transvermian, or the approach Slaven today discussed is the just from below the cerebellum, which is the tilovelar approach. So this will help us to decide what is the lesion and what's the approach needed. And another section we needed is the axial section like this. So if the lesion in that area, in the lateral part of posterior fossa, what will be the best approach, what's the shortest and the safest approach. So I just want to put in mind these 2 pictures for imagination. These should be all in the mind of surgeon to decide what's the approach, because all of these can give you maybe to the cerebellopontine angle, like this last example, like this mass, and you can reach it. And there's 2 more anatomical points. Is the venous system, very important when we are discussing about the posterior fossa. So the transverse sigmoid sinus, one of the most important, and actually any misunderstanding of their anatomy may be fatal to the patient, especially in children. They are the most important structure there, with the brainstem for sure. And the last point that actually I find it here in Japan more, when they open the posterior fossa for the posterior fossa approach, they can identify each muscle one by one very clearly during surgery. So if you know all the layer, it's not simple one. You must study it perfectly in anatomy. And actually, I'm amazed at when I see all the muscle like superior oblique, like semispinalis, like splenius capitis, all can be seen and removed apart and according to origin and insertion, and they use it also for other management. That's the point that I want to share with you. And
very, very good, Sarah. Thanks for the clarification. It's a little more understandable what Slaven was showing. And let me introduce Emmer to Elena. Can you Emmer and the rest of the audience there, Elena? Can you hear me, Elena? You're on mute. Oh, maybe she may be frozen there. Okay, anyway, Joseph, can you
Hello, everyone.
Sammer Hose?
Yeah.
Oh, thank you, Joseph.
Hello,
This
Elena.
is Dr. Sammer Hose from Iraq.
Yeah. No, Yusuf from Pakistan. And hello,
Okay.
Elena. Hello. Hi, Samir, and hi, Slaven, and hi, Dr. John Bennett. It was a pleasure to be here. And Slaven, you did a wonderful presentation. And
yeah, thanks a lot for the added section there, Sammer. So how are things in Japan, Sammer?
it's perfect. I'm wondering if anyone of Yusuf or Ilana have any question. Just
You have any questions,
about this
Elena?
topic.
So far,
Or
not.
Joseph?
Very general.
Questions for
Dr.
Okay,
Samer,
thank
it
you,
was,
Elena.
yeah, it was quite understandable. Thanks a lot.
Yeah, thanks for the clarification, Samer. And you're welcome to give any presentations that you would like. We're going to have next Sunday. Every Sunday we have these. And I'll be heading back to Miami next. Have a better connection, hopefully, and we'll continue on with these presentations.
Just perfect. I would like to comment more. It's better to comment than to give presentation. I would like the young generation to give the presentation and we can comment. That will be a better idea.
Very good. Okay, thanks everybody for coming.
Thanks. All the luck.
Thank you. Thank you, Elena. Thank you, Joseph, Samer.
Bye-bye.
Welcome. Have a wonderful Sunday.
Have a wonderful Sunday. Bye-bye.
Bye-bye.